Thank you. I changed my title a little bit from what's listed in the program, and I have 3 goals with this presentation. I want to start by reflecting a little bit on what we've learned from the development of alpha blockers and 5-alpha reductase inhibitors. It's been almost 50 years since the research that contributed to the development of these drugs was initiated, and I think we can learn a lot by looking back. I second want to talk about some of the contemporary methods that we've integrated into a pipeline. And third, the focus of our O'Brien Center is on fibrotic disease within the urethra and the prostate. And I want to talk about how some of these contemporary approaches can help us to better develop drugs to combat that particular disease process. Back when I was a new faculty member, I got great lab space, but one of the things that I regret is drawing the short straw on my teaching assignment. I was assigned to teach pharmacokinetics to vet students, and I can't think of a topic that's even more dry than that. Certainly it's important, but it's hard to learn. And so I thought maybe one way to capture the interest of the students was to scare them into the importance of drugs. And part of that process, I developed a lecture in the very beginning that focuses on the history of drug development and the fact that most of our regulatory additions in this timeline were driven by pharmacological disasters. If from the very beginning here, people putting organophosphate compounds into their patent drugs to throw off copycats that might want to make similar drugs, to the addition of propylene glycol to sulfanilamide before it was used as an antibiotic syrup in kids. You know, even recently, as we look at the COX-2 inhibitors, the integration of phase 4 post-market surveillance to identify disease processes. In this case, it was cardiovascular disease. But I want to focus in on these 2 different elements of the timeline, the Harris-Kefauver Amendment and then accelerated approval, because it was during this window that alpha blockers and 5-alpha reductase inhibitors were developed. And many of you know the Harris-Kefauver Amendment was a reaction to a horrible tragedy in Europe at the time. A drug known as thalidomide was approved in Europe for the treatment of, it was used as a sleep aid and also as a sedative. It was not particularly effective. The FDA in the United States did not approve it because it didn't look to be effective, but it went on to be approved in Europe. And then it started to be used off-label to treat morning sickness. And it resulted in congenital malformations in 10 to 20,000 individuals in Europe. This is a tragedy. Thalidomide probably shouldn't have been approved because it's not particularly effective as a sleep aid, certainly not as an agent against morning sickness. And this phenotype, these congenital malformations, were predictable. Had individuals done preclinical testing in animal models, here you can see thalidomide was added in ovo to chicks, they would have been able to predict that it was a teratogen and prevent this from happening. So we got this Harris-Kefauver Amendment, which said that all drugs needed to be proven effective. That was a heavy burden for many drugs, and it took a lot of time to prove that a drug was effective. Fast forward to the early 1990s, we were dealing with the epidemic of HIV and AIDS. The endpoint for proving that drugs were effective was an increased survival. And those studies took a long time, and they were cruel for those who were living with HIV and AIDS at the time, because there were many drugs that looked to have therapeutic potential, and those individuals couldn't wait 10 years, 5 years, even a couple of years for those drugs to be approved. And so they stormed the office of the FDA director, and patient advocacy groups demanded that we start to consider surrogate endpoints for as evidence of efficacy and not just survival in this particular case. So I like to challenge the students when I teach them to wake them up a little bit by giving them synthesis questions. So this would be the type of question I would give during a lecture. A promising therapy for benign prostatic disease deriving from basic science research will A, relax the prostate, B, shrink the prostate, C, increase Wilrecke's wealth, or D, treat urinary symptoms and dysfunction. I know what Will's voting for here. The other answers might not be so simple. Many of you might say, well, of course, we want to treat the symptoms and urinary dysfunction. But back when 5-ARIs and alpha blockers were being developed, we were so convinced that we knew the source of benign prostatic disease. It was prostatic enlargement, or it was prostatic increased muscle tension, that we were a little bit sidelined in terms of thinking about what the endpoint would be. We decided instead we could use these as surrogate endpoints to demonstrate drug efficacy. Okay, so just going over a little bit of history of each of those. On the left, the development of alpha adrenal receptor blockers, or alpha blockers. The initial observation in the late 1960s was that noradrenergic fibers existed in the prostate. It was a surprise given that cholinergic fibers dominated in the bladder. Some ex vivo muscle contractility assays demonstrated that adrenal receptor agonists would drive muscle contraction. Of course, we have to argue the importance of those findings. So in the conclusion, the discussion section of that paper, they argued that maybe this is important because some might harbor excessive smooth muscle tone. And while we know that men experience bladder outlet obstruction, we know from urethral pressure profiling that there's a bottleneck at the level of the prostatic urethra. We don't necessarily know why. It could be enlargement. It could be excessive muscle tone. It could be something like fibrosis, which we'll talk about later. So we didn't really prove that men have excessive prostatic muscle tone. Went on to synthesize alpha blockers. We tested that they did in fact relax prostatic smooth muscle, but we didn't test using preclinical models whether they reduced LUT-D because we didn't really have models to test for those particular endpoints. And then they went off to human trials and they were approved. Going to the right now, this is the development of 5-alpha reductase inhibitors. A couple of different studies had identified individuals with variations in sexual development. Those were tied to sequence variations in 5-alpha reductase that resulted in inactivation of the enzyme and the inability to synthesize dihydrotestosterone. Those men carried small prostates with them for the duration of life, and investigators said, wouldn't that be a great drug if we could shrink the prostates? So 5-alpha reductase inhibitors were developed at that point. It was never tested whether they would reduce lower urinary tract dysfunction in preclinical models, but instead, as long as they were to reduce prostate volume, we were so convinced that that was the endpoint that was important, that was the endpoint that was used. And then they went on to human studies and they were approved. I don't deny that either of these drug classes offers benefit. They do in most men. The degree of benefit is not large, maybe 5 to 7 points on the International Prostate Symptom Score. They only reduce clinical progression by about 35%. They come with some side effects. We could probably do better. So I want to ask the question, will it help us to integrate rodent models and urinary physiology in rodent models into the R&D pipeline to improve drug development for BPH and LUTs? Many of you in the crowd are listening to this and saying, heck no, because we've seen that happen before at other conferences, in study sections. No, because the mouse prostate looks entirely different than the human prostate. Well, to our surprise, Doug and I, led by Dia Joseph, just did a study and it was published in Journal of Pathology. The types of cells that are present in the human and mouse prostate are transcriptionally very, very similar to each other. So though the anatomy differs, the cellular composition is pretty similar. You might say, well, we know that mice don't develop benign enlargement of the prostate with age. They certainly don't develop any symptoms or lower urinary tract dysfunction with age, like we have seen in humans and dogs. And that was true for a long time. This is a really important paper by Teresa Liu and Will Rickey that said, in fact, they do. And it turns out we just never bothered to look. You know, with humans, urinating more frequency is a bother, especially at night. It draws our attention and we seek therapy for it. With our pet dogs that are housebroken, urinating more frequently, especially at night, it draws our attention and we seek therapy for it. With our pet mice or our research mice, we put them in a cage and we don't bother to look. Teresa did look, and in fact, prostate grows larger with age, and mice do develop voiding dysfunction with age. One might say BPH LUTs is a disease where the patient's symptoms, reported symptoms, are really critical. And I just told you that the endpoints that we need to consider are the symptoms and the voiding dysfunction and not these surrogate endpoints. And we certainly can't do that in mice that can't communicate their symptoms. Well, it turns out we've gotten really good at predicting urinary physiology. This was a paper that we published recently where we took different mouse models. We had one of diabetic diuresis, another that had irritative symptoms, another that had obstructive symptoms, and we measured their voiding physiology, various elements of voiding physiology. We reduced the dimensionality of all of those elements of voiding physiology so that each point here represents a single mouse. And we can find that we can separate mice based on their disease processes from the symptoms that we can measure from them. And what's really interesting here is that if you take a disease process such as aging, which can manifest in a variety of different ways, we actually see that happen with our mice. Well, some develop what appears to be a diabetic diuresis pattern. Others develop what appear to be an obstructive pattern, and others an inflammatory pattern. Okay, so let's think about those resources that relates to this new element that we think is related to BPH, LUT-D in men, and that is the accumulation of periurethral collagen. This is an image from Ryan Hutchinson, Jeffrey Gahan, and Doug Strand's group. This is an MRI image at the level of the prostate. And here we can see a couple of nodules. These are benign prostatic hyperplasia. And right between them, we can see this band of tissue that, taking that same sample after a radical prostatectomy, here we can see this, this whitish colored material that's super elastic, and this is periurethral collagen. The urethral opening is right here. Taking a histological section from that same specimen shows this eosinophilic concentration here next to the urethra. This is also collagen. So we think we have imaging modalities that can see collagen in the prostate of some men. We saw this at about 30% in men who have simple prostatectomies. We have a histological method that we can use to stain for collagen. This is a dog prostate. Zooming in, you can see these collagen fibers. We developed quantitative methods to measure the density of those fibers and their organization. In looking at men across age, we noticed that collagen fiber density increases, particularly in the periurethral area. Using mouse models where we've integrated sequence variations into the collagen 1A1 gene that render it resistant to degradation by matrix metalloproteinases such that it accumulates over life. Teresa Liu, Will Rickey's group, and others have been able to show that this model accumulates collagen within the prostatic urethra and bladder, and it also succumbs to urinary retention, which is something that we see as men age. So beyond observation, these new tools using mice have allowed us to determine that collagen accumulation is in fact a causative variable for urinary dysfunction. Now, we know that there are a lot of different causes of voiding dysfunction. We didn't know this back when alpha blockers and 5-ARIs were being developed, but we do now. And we've been developing and really very carefully phenotyping mouse models to represent all of these different causes of voiding dysfunction. And then we can ask the question, where is collagen accumulation important? In which of these different disease processes? Two that we've observed so far is in inflammation, we see collagen accumulation, as also in terms of aging. We've been able to go in and, using genetic strategies, identify which cells are contributing to collagen synthesis. This is important so that we can tailor our therapies against those particular cells and the collagen synthesis mechanisms within those cells. We have observed that circulating cells that are bone marrow derived are responsible for collagen synthesis, and they proliferate when they land in the inflamed prostate. We've been able to determine that those cells are necessary and sufficient for driving collagen accumulation. Here we've knocked out a critical receptor that's necessary for the homing of those cells to the prostate. It wipes out collagen synthesis in response to inflammation. We can give it back by feeding bone marrow, wild-type bone marrow cells into those mice. And finally, we've been able to show that antifibrotics are effective in treating both collagen accumulation over here. This is in isolated prostate stromal cells in a dish, as well as treating voiding dysfunction that occurs spontaneously with aging. And this is work by Teresa Liu and Will Rickey's groups. And so I think that these preclinical models allow us to better steer our therapies and to target very specific pathways that we think are responsible. I want to thank everyone in my lab that contributed to this, specifically Jaskiran Sandhu, Hannah Ritten, and Brandon Sharp, who have led a lot of the work with the mice. Thank you.